I'm Gary Weil. I'm the chairperson or organizer for this session, and thank you for coming. I think it's going to be high. We want you to rate it as the best part of the entire meeting. And Molly Mort is in front here, who was important for these IDA rollout and monitoring and evaluation studies. And Katie Gass, who's also part of the meeting, wrote the protocol that the studies more or less followed. As you know, I think clinical trials and community studies show that a triple drug regimen of IDA was safe and more effective for clearing microfilariae than the two drug regimens that were used, IA and DA. So in November of 2017, after a long process led by Jonathan King, who's also speaking today, there was a WHO policy change, and this expanded with that there was an expanded donation of the drug ivermectin from Merck. And this was going to be very exciting, but we all understood at the time that a better regimen alone cannot fix underperforming programs. And time has borne that out for sure. There's something called the Gartner hype cycle, which I think is interesting regarding innovation and change. And what it is you start with, I don't know if this, you have this need, so some technology advance occurs, takes some time for people to realize what it is. Then there's a peak of inflated or unrealistic expectations. And then as people get experience, what they're calling is the trough of disillusionment. And I think for IDA, the trough is not as deep as that, but certainly the peak of unrealistic expectations, we're not quite at that anymore. And then with time, as people get to use the new innovation, there's what they're calling here slope of enlightenment. How to best deliver your new innovation, and what are the best situations for it where it actually is useful, and they call it plateau of productivity. This is a very interesting thing that would apply to any innovation. It actually comes from the business world. Somebody at Harvard Business School came up with this. And here there's an article, recent article in a journal called Medical Education that is talking about this in their field. But anyway, we've seen this, so the Gartner hype cycle. So today we're going to, where are we now and what to do next, where to go from here. There are overview talks by Jonathan King and Allison Krentel. That was going to be virtual, but she's going to be here to give a talk. She's in high demand. She's in pretty much every breakout session. Then there will be project-specific talks from leaders of the large operational research studies that were performed in Kenya, India, Papua New Guinea, and Indonesia. And then if there's a burning question, we can take question after the talks, but after all the talks, there'll be a 15-minute question period, so you can write down your questions and ask them then. Then we're going to have a small group breakout discussions, and we've pre-circulated the topics that we want to discuss, 3 groups of topics, so that people can self-select to their group. And after some time, we will have them people rotate to the next group, so you'll at least have a chance to comment and weigh in. And there are group leaders for each of these 3s. Then we'll have this reports from the small groups and closure. And the rapporteur for the meeting is Philip Budge, who will make the report. So these IDA studies, in part, they were to evaluate new or best practices for monitoring and evaluation, especially with triple drug. But they were also in part to get countries used to using and get real-world experience on large-scale use of IDA. Many countries, as you heard from Jonathan, are using it, but already. But in other cases, people wanted to see more evidence, more of their own experience. Now it's, with the pandemic and everything, it's 6 years since the policy change occurred. But to some of us, the adoption of this has been slower than anticipated. So I think that's enough from me. The first speaker is Jonathan King. He's among many other titles, He's the focal point for lymphatic filariasis elimination at WHO. So here you are, Jonathan. It's just like,
Thanks. So all the slides.
yeah, and all the slides run together, so you don't have to.
Very good. Thanks, Gary, and good morning. So I just wanted to give a brief progress update, and everyone is aware, hopefully, of the 2030 targets in the roadmap and where we aim to have all countries have been able to pass Task 1 in all areas, or IDA impact survey in all areas, and MDA no longer required by 2030. And a significant proportion of countries, 81%, being already achieved the criteria for elimination of LF as a public health problem. Wow. It's a micro advance. Okay. That stuck. So over the weekend, our latest weekly epidemiological record came out showing the progress in the global program to eliminate lymphatic filariasis as of 2022. Unfortunately, we're a year behind. But as of 2023, there's 19 countries that have achieved the criteria of elimination as a public health problem, and WHO has acknowledged those countries, with the latest being Bangladesh and Laos PDR. 13 countries have been able to stop MDA nationwide and are under post-MDA surveillance. The majority of countries have scaled MDA, at least reached all endemic areas with at least one round of MDA in 31 countries, and that's getting too crowded. There's a lot of countries there that have been doing MDA round after MDA round, and a lot of progress within the countries, meaning subnationally they've scaled down in many areas. 8 countries still have not reached all endemic districts or implementation units with MDA, and we all need to support Gabon to make a decision on whether MDA is needed or not. For IDA, now I know that just a few weeks ago, Haiti was able to implement the first round of IDA, so that's very exciting, and they should shift over into that next column. So 10 countries have done IDA in some of the implementation units. 6 countries now have reached all endemic implementation units in the country using IDA. 4 countries implemented IDA, conducted surveys to monitor the impact to show that MDA is no longer required, so they had achieved the criteria for stopping MDA. So there's 5 countries that haven't started. Now Haiti should not be there, so 4. Eritrea completed MDA with 2 drug MDA in 2 endemic IUs, and that was the total number of endemic IUs in the country. And they conducted a mini task, or kind of like the confirmatory mapping protocol, except they tested many more children with the median age of 12 years and found 0 positive. So really, no MDA is no longer required there. FSM is still awaiting to implement a survey that they've been trying to plan and trying to get a boat out to the island to complete the task. Zambia, the entire country was eligible for pre-TAS or TAS, and until those results are known, then we don't know whether or not that they would require MDA, but they would be eligible then for IDA. And Zimbabwe has done a series of confirmatory mapping, and they, depending on the retesting of the FTS positives, they either have 4 or 7 IUs that would require MDA, but overall there's very low endemicity. So there's now over 149 million IDA treatments that have been reported by the 20 countries, and the reported coverage has been above 65%, the coverage that's reported to WHO. Obviously in 2020 and in 2021, there was impact from the pandemic. If this chart removes India from the picture, and outside of most of the programmatic disruptions due to the pandemic, there's kind of been an increase in uptake and expansion of IDA into new implementation units. But the coverage that's being reported back to WHO, when you look at it overall basis, is above 65%. Now, how do we monitor and evaluate IDA? Well, at this moment, we're undergoing a process of updating the M&E framework for LF. The first edition of the so-called task manual was published in 2011. There's been lots of changes. We've learned a lot from the data and implementation of tasks and other research, and we're making some significant changes. I wanted to highlight those here because it's relevant to the M&E of IDA. One significant change is reducing the maximum limit of population size of an evaluation unit. Before, it was less than 2 million population for an EU, and now we recommend less than 500,000 total population per evaluation unit. And of course, any IUs or districts that are combined to make one EU must be similar in characteristic and geographically contiguous. Instead of the pre-task sentinel and spot check site monitoring, we're calling or referencing this to epidemiological monitoring survey. And the timing of when you do that depends on the MDA regimen. It can be 6 months after 2 drug MDAs, as it was in the previous version. But with IDA, after a series of consultations and looking at the data available, we would recommend this happening 10 to 12 months after an IDA implementation. And we're suggesting random selection rather than a convenient sample of 300 adults, 20 years and above. And the threshold can remain less than 2% antigenemia, but in areas that are under IDA, the threshold can also will be less than 1% MF among adults. So if it's a 2-drug area, the threshold of less than 1% MF could also be used. And we would recommend night blood films be taken from persons RDT positive, so not an entire night blood collection from the whole 300, but only those testing positive with the RDT. So a significant change that's being proposed for the task is to reduce the threshold to 1% for all vector areas and to maintain the sample size, the existing sample size for Culex, Mansonia, and Anopheles areas, with the maximum sample size being 1,692 kids 6 to 7 years of age. So it's still recommended in this age group, but a lower sample size, a lower threshold, and that means that you can accept up to 6 positive children in the task. And then we introduce the IDA Impact Survey, which is a community-based cluster survey only among adults 20 years of age and older. And we recommend doing night blood films to check for microfilariemia in those that test RDT positive. So the timing of after how many rounds depends upon the setting that IDA was introduced. Those late starting districts would complete 2 rounds of IDA followed by the EMS and then the IDA Impact Survey. If you have a setting such as what Timor-Leste had done, 3 rounds of 2-drug MDA, they introduced IDA for 1 round, then they did monitoring and they used the existing tasks, which we had recommended as acceptable. And then in a lot of the settings where IDA is being implemented, it's in areas that have failed a pre-task or failed a task, had many rounds of MDA But we recommend 2 rounds of IDA before measuring impact. So these countries are shown here where they've implemented IDA based on the setting. So Sao Tome, Principe, Egypt, Guyana, India, PNG for setting A, the late starters. Setting B, 3 prior MDAs, Kenya, Timor-Leste, PNG, that's New Ireland province. And then setting C, American Samoa, Samoa, India, Indonesia, Malaysia. All of these countries have done impact surveys. I know that some of you will present some of the results, so I did not put the outcomes in these. So thank you very much. Oh, sorry, this is just a summary of the new approach, but we don't have to go through that.
Thank you, Jonathan. If there are any burning questions, just clarifications of what he said, otherwise wait till later. And some of these changes are complex, and I think probably will require reading the new WHO report. Sure.
So if you are affiliated with the Ministry of Health and you are a program manager or NTD program manager, raise your hand. Okay, 1, 2, okay. Have you seen a questionnaire that's been circulated from the regional offices to get your feedback on some of the newly proposed changes? If you haven't, please come to me immediately after, because I have a hard copy, but I can also send you an electronic link for you to give your perspective and feedback on what's being proposed. Thank you.
Thanks. Although not many program managers are here, a lot of the people who are here know the program managers or work with them. The next speaker is Alison Krentel. She's a professor at University of Ottawa, and I hope she's here. There she is. Who has really been a pioneer in this whole issue of improving, whatever you want to call it, reducing never treated, improving compliance coverage. And Alison is going to give us an update. She also went to many of these IDA studies.
Hi, everyone. Nice to see you. And thank you for inviting me to be here and share a little bit about the importance of central and regional preparation for MDA with IDA. And I'm going to be largely speaking from the perspective of acceptability, but I'll also bring in some other ideas. So I'm just going to share a bit what we've learned over the years from our acceptability studies, can bring forward some of the best practices that we've learned over the last few years, and then some new and emerging issues that we need to consider moving forward. So as Gary mentioned, we were involved with the community-based surveys that Dolph led in those 5 countries in 2017, and then subsequently we've been involved in acceptability studies in Guyana, Kenya, PNG, and Indonesia for the rollouts. And that's involved sometimes a pre-MDA IDA study and sometimes a post once or twice. So we've been able to collect quite a lot of data over the course of the last few years. So the measure that we use, and I've presented this several times, so it's probably something many of you have seen before, but we use a 9-question or 9-statement scale, and the spider plot in the middle has those questions there. They're questions around effectiveness, relevance of the treatment to yourself, do you like it, would you recommend it for other people, and then we're able to calculate a mean acceptability score. And on the right are the mean acceptability scores from the community-based Dolph-led study. And you can see that there's a lot of variation there. When you look at the spider plot in the middle, you can see the gray line is India, for example, and we can see some of the reasons why India has lower acceptability compared to the other countries, which relate to agreement that the drugs work against intestinal worms, or the drugs work against itching, or the treatment is a good way to help our health problems here. And so in those areas, India in particular scored lower than the other countries. So it gives us a measure that we're able to compare across different countries. in some sites, we've been able to measure multi-year acceptability scores. And so the graph on the left is from Guyana. This was a pre-IDA rollout, and so this was acceptability based on the standard 2-drug treatment across the regions, the yellow bars being the DA and the blue bars being the IDA after round 1. And you can see there, we see sort of a general trend of increase after the introduction of IDA. On the right-hand side, we see PNG. Here, we were able to capture acceptability after round 1 and after round 2, and we see a slight decrease across all 4 areas. Pomio, we were not able to collect due to a variety of factors, so we only have 1 round of data for Pomio. So some of the factors that we consistently see are associated with acceptability. The ones that are bolded in the top are the ones that are consistent mostly across all sites that we've seen. So context is most important. There's a lot of variation between country. There's variations within country. Context is very important. Taking the treatment at least once is associated with acceptability. So the inverse of that, lower acceptability, is consistently associated with never treatment. The 2 messages that arise of importance across the board are the perceived importance of MDA for community health and perceived importance for personal health. And both of those remain really important messages. So when we think about regional preparation for MDA with IDA, these are some key messages that can be used when considering the social mobilization and new approaches. Gender is interesting. Sometimes it's important in one area and sometimes it's not. So it's not one we see consistently between men and women. Whoops. So, well, okay. One more. There we go. Well, I don't know why this is jumping. There we go. So in terms of preparation, one of the important parts of the pre-MDA IDA assessments is using that information to inform the social mobilization. So we want IDA, when it's first introduced, to be new, to be dynamic, to kind of provide some new life into the program, particularly in those areas where it's being used after failed evaluations assessments. So the slide on the left, we used in Kenya to develop a new social mobilization campaign, and Wycliffe is in the room. He was instrumental in that process. We did a similar process in PNG with stakeholders, and then the picture on the right here is from Indonesia. It was taken a month ago with each of the puskesmas, or the primary healthcare centers, creating their own social mobilization plan for their catchment area. And Tanya, who's here, was part of that as well. So in the IDA rollouts, this has been a really important part, is to think carefully about what are the best messages to use for that population and for that context. When we think about preparation, one of the opportunities that we have with the introduction of IDA is to bring a new approach to mass drug administration. So obviously, height-based dosing has been very important as sort of signaling a new way to deliver treatment. It also kind of it helps to encourage the directly observed therapy, because you have to be there to measure someone's height. And we've seen, certainly in Indonesia, that was a big focus that they wanted to work on this year, was making sure that DOT was going to be, in Belitung, was going to be carried out. It also gives us a chance to reinforce eligibility criteria. In many countries, there's sort of some additional groups that are added in that aren't in the WHO guidelines, where we aren't delivering treatment. And so it's a chance to reassess what are the national guidelines for eligibility criteria, and have they slid a little bit from what WHO is offering. And to give you an example, some countries have an age limitation. Other countries don't treat people with hypertension, for example, or diabetes. Long-term, illness is considered very broadly. And so this is a chance to kind of rethink what actually the national guidelines are for eligibility. There's also a real heightened attention to management and reporting of adverse events, and this was particularly clear in Kenya, where there was a very good cooperation with the national pharmacovigilance groups, and this helps to reassure people in the introduction of the new treatment. So the IDA rollouts give us a chance for renewed political commitment. the public launches of IDA, ministerial interest in LF elimination, seeing the possibility for acceleration. This is a really important part of those regional and national preparation to ensure that there's a rebrand and more energy and life that's brought into the program. Oh, wow. This is amazing. Sorry. It's really fast. In terms of the IDA rollouts, another opportunity in terms of thinking about preparation is how to better support the workforce. So whether it's a community volunteer workforce or your formal healthcare workforce, and this is taken from East New Britain province and PNG, some of the successes that were reported there by the research and the data that we collected by the health systems. They felt that they had adhered to DOT, they were equipped with what they needed, they felt that their system worked. And then on the right side of the slide, some of the challenges that they faced. And I think a lot of these are probably challenges and successes that we could apply in other countries as well. And so building in support for that workforce is really important in the preparations. So 2 emerging issues to leave you with. We haven't collected enough data yet, but there appears to maybe be a decline in acceptability after rounds. We know that probably there's fatigue in MDA over time. By measuring acceptability over time, we're able to kind of track this. This is just something to be aware of, where the data still needs to be, we need to collect more data on this. But it certainly reiterates the importance of the window of opportunity of those first 2 years of rollout of MDA, IDA. It's really important to get that right and maximize the coverage as much as possible. Of course, I would always suggest to include a measurement of acceptability because it gives you a chance to track that over time. The other emerging issue is around never treatment. Some of you were in the session yesterday afternoon on this. IDA has a chance to reach people who've previously been never treated. So if you've tracked that number, it's a chance to boost your program. And again, a recommendation to add that question to routine evaluation surveys as a way to track and measure progress and impact of IDA in terms of improving coverage. So finally, we do have a possibility to increase acceptability and reach never treatment with the introduction of IDA. In terms of preparation, it's important to think about the kind of data that you want to collect over time in the rollouts of these so that you can track some of these indicators. We do believe and demonstrated that the value of social research in achieving high coverage and acceptability. And I think just some very rapid surveys that are done before the MDA can really help to direct the way social mobilization is going and to help to have context-specific approaches. And just a theory, the novelty of IDA may wear off. So we really do need to think carefully and prepare well for 2 really solid rounds in the beginning. And then if you need to mop up in certain areas, that's possible. But I'll leave you with that, and thank you very much. Thanks, Gary.
So because Allison has to run off to chair another session, if there are questions about her presentation, we can take a couple of questions now. This ends up being a marketing exercise, introduction, in addition to, which also comes from business. I think we need more input from marketing people. But there's one question back, Yao.
Sure. Thank you very much, Alison, for your presentation. I picked a keyword which is rebrand a program. This is certainly something that can be very can be possible in setting with very small countries like Sao Tome, even in Kenya, where the first round is created a lot of enthusiasm. Mm-hmm. My question is how this happens in settings like a big country, India, after the rollout, where you saw a lot of enthusiasm, when they are expanding to new communities, how this works. Are they able to rebrand the program in those new districts? That's my question. Or is it fading and, of course, with low coverage? Make sense?
Yes, it makes sense. It's like $1 million question. Thanks, Yao. No, I think it's obviously in the smaller countries, it's easier. Because you have a smaller structure. But to give an example, in Indonesia, in Belitung, which is a beautiful place if you ever get to go there, but to think about Belitung, they want to grow their tourism industry. So working with them, the message that they need to be thinking about is if you want to be a tourism center in Indonesia, you need to get rid of this disease. So in terms of encouraging the district health authority, that's a powerful message. It's really it's very relatable for that particular district. So I think in places like India, it's hard to think about the whole country. It's even hard to think about the whole state. And so I think equipping at the lower levels as much as we can is going to make the bigger difference to help rebrand. And I think that's one of the things we've seen consistently is looking at things on that macro level is really challenging. We need to be thinking at the lower levels to really try and understand that context. And whether it's a district or whatever that level is in the country, I think helps to make it more easier to think about as opposed to a massive country level. I don't know if that answers your question. Yeah.
Yes.
Alison, what I would like to talk about adverse events and pharmacovigilance awareness. Is there enough evidence of safe treatment during the disease? So there's a part of it.
So I think the research that came out of. Oh, go ahead. Do you want to restate it? Oh, it was just a question about the adverse events and do we need to pay more attention with IDA versus the standard treatment? And I think the data that came out of the community-based study, which Gary can talk to more, showed the levels were the same. What we measured in the acceptability study at the same time was this discordance really between people's memory of the impact of those adverse events. So because they were really reassured by the whole trial, they didn't note their adverse events as being important. So I think it's more that in the IDA rolling out, you're giving more pills. It's an opportunity also to reassure people because side effects or adverse events do remain the main reason people don't want to take pills. And so if we just put even simple structures in like a hotline or a Facebook page that people can send a message to, even doing something small can help to reassure people, and it makes a big difference. They know where they need to call if they have a question.
Thanks.
Thank you. Yeah.
Now she'll run off and share her other session. We need to clone Allison. Right, the next talk is by Dr. Sami Jenga. He's the Director of Research at the Kenya Medical Research Institute, and he'll talk about their experience with a rollout study in Kenya. Sami.
Good morning, all, and thank you so much, Gary, for putting this together. And I'll present. All right. So the work that I'm presenting here is operational research that we have done under the IDA program in Kenya, and I'm pleased that the NTD program head is here, Wycliffe. Because the implementation of the MDA with the IDA was done by the Ministry of Health. We will focus on the baseline results and the first impact surveillance. So in terms of background, just to say that in Kenya, lymphatic filariasis, LF, is endemic in the coastal region. And we estimate that slightly above 4 million people are at risk of the disease. The program is not new in Kenya. We started our national program in 2002, but faced serious challenges, and the program collapsed at some time, but it was restarted 2015. Most of you have met Dr. Sultani Matende Chero. He brought in a new innovations in terms of management and resource mobilization, and we restarted the program in 2015. For IDA, we selected 2 areas. An area north of Mombasa called Lamu. It's comprised of many islands, and an area in Mombasa called Jomvu. Now, in terms of research questions and objectives of the study, we have many in the broader protocol, and all this is around what Jonathan presented on the task that is existing. We were asking ourselves, for IDA, in terms of strategy, would the purposefully selected sentinel sites still be adequate, or do we need to focus on random sites? Will the detection of antigen in children 6 to 7 years still be suffice, or do we need to think of including other indicators, for example, antibodies in children? We have collected dry blood spots. What about antigen in adults in addition to children? And the role of microfilaria. Particularly, we knew that in our area, we had given MDA very well with the diethyl carbamazine and albendazole, and the prevalence was quite low. And finally, we are asking ourselves, what's the role of molecular xenomonitoring? In terms of timeline, the MDA has been given two rounds in 2018, 2019, and before the MDA, we went in and did a baseline survey in October, November 2018, and we have done an endline assessment in 2021, 2022, soon after restrictions, COVID-19 restrictions were lifted. We have 2 arms. We have an epidemiological or population-based human survey, and we have entomological survey where we're collecting mosquitoes in the same areas. However, I needed to say that we'll not be focusing on the entomological survey this time. We are focusing more on the epidemiological, which is shown here in this slide, that we are focusing more on the population-based epidemiological surveys. So in terms of the testing, we collected blood and tested for LF in the blood using the FTS cards, and those who are positive are also tested for microfilaria. But as I said, we have collected DBS, and we are currently testing for antifilarial antibodies. And we're also doing molecular xenomonitoring using PCR in the lab. Sorry, this thing exists. It has to do this to everyone, so I'm not spared. All right. In terms of treatment coverage, the program has done exemplarily. As you can see, we have our IUs are sub-counties, which in other settings we call districts. So Lamu, for operation research, we combine these 2 because of the population, but the program still maintains them as independent IUs. So you can see round 1, we did over 80%, 80 and over 80%, and the same in round 2. Jomvu did very well. It's a peri-urban area and did extremely well. So just to echo what Alison said, that coming with IDA gave us an opportunity to maybe sell the program to the community and other stakeholders. In terms of the results that we have obtained, if you look at panel on the left side, that is Jomvu. You can see we started, the prevalence in Jomvu was way above that in Lamu. However, if we categorize the prevalence, you can see those which were 2% and above, they were more in Jomvu and very few in in Lamu. After the IDA, we have seen a dramatic reduction, and when we measure this, we have measured the relative reduction to be quite significant in both areas. Although the prevalence in Lamu was low, there was significant reduction. So you can see the reds in Jomvu declined, the red and the orange. But we have an area here in Lamu, which still remains. The same information, we are only now focusing on Jomvu. You can see the baseline where there is the round cycle, and the end line is the triangle with the 95 confidence intervals. And you can see generally there was pretty good reductions in this area. IDA seemed to do to reduce the 2 rounds. Now we ask ourselves, how do we compare with the WHO task? Because we wanted to decide, are we stopping the IDA or do we continue with IDA? And we did an assessment based on similar to the WHO task. And we had 39 clusters in Jomvu at end line. The reason is we had 30 random and 9 were purposefully selected based on prevalence in children, prevalence we found in mosquitoes. So we had 9 extra, and in Lamu we had 6 extra. In terms of sample size, we focused on the 5 to 9 children, and we found we had this kind of population. Critical cutoff, if we are to compare with the WHO, we did tasks. The critical cutoff in Jomvu would have been 16, Lamu 18. We found only 3 children positive in Jomvu and 0 in Lamu. So we agreed that as a program, we were quite safe to stop IDA. In terms of discussion, the results of the end-line impact assessment supported stopping of IDA. And however, we note that there are clusters that are still positive. We need to implement a surveillance system to detect any recrudescence. And we have also, as I mentioned, we have collected samples that we are analyzing for molecular xenomonitoring and antibodies. So we need to see what additional evidence we get from these indicators. So hoping that early next year we can do this. But overall, we have said that the operation research in Kenya has enabled collection of data that might be useful to guide M&E of programs that are using IDA. Gary asked me to do this slide after submitting, so asked me what are the lessons, and these are some of the things that we thought about. There was high compliance of MDA with IDA, and thinking through it, some of these are what maybe Alison mentioned about, but we think sorry about this. We are thinking about the partnerships that we established for the IDA implementation. We have the MOH was leading. We had KEMRI, we had Evidence Action, we had African Institute of Health and Development, and we had international partners. The NTD Support Center, COR-NTD, and NFAN played a significant role. Then the role of intensive advocacy, communication and social mobilization, so was quite intensive, and we involved champions. So there were champions that were involved in this, so that we can develop more interest. I remember when we launched the idea in Lamu, we also involved very high-level leaders. The governor of the county was there and swallowed the IDA medicines in front of everybody, and that was a very major thing. Then there were innovative IDA delivery strategies that were employed. In Jomvu particularly, we were fearing about coverage because people there are working in town, in the industries, but innovation helped to reach these people by by going to the industries and talking to the management and reaching the people there. And use of speedboats to access remote islands in Lamu. Then the other lesson that we are seeing is that the adult population and randomly selected villages might be useful for IDA, and I'm glad that Jonathan is already thinking about that. But also, we should not forget that our purposeful sites were able to, they were the areas that we found to have higher risk of infection. So they are good for identifying hotspots. For example, in Lamu, we have Ndau, which even after endline, we still see it remained red. So our next steps, we want to publish these studies, these results in the coming months by December, and we are planning for impact surveillance 2 in November 2023. And a lot of discussions have gone through this, and I'm happy that Katie Gass is here. She has given a lot of technical advice on how to do this, and we'll be also including secondary analysis with Peter Digo, who is here, to see the role of model-based geostatistics in this. And then the other remaining work, which has been pending because of various issues, is the laboratory work, the multiplex serology, and the PCR but we are hoping to complete this December and January. Everything seems to be in place. I cannot end without acknowledging various partners. As I mentioned, this is work by many, many people, and everybody contributed immensely to make this successful. Thank you very much.
Those were exciting results, Sammy. It shows that Kenya's well on the way to being able to stop MDA, although you have to snuff out these remaining hotspots. And quite a lot was learned from this study, although I think it illustrates the potential use of IDA as an endgame strategy in areas that are, like Kenya, that are close to elimination already. But it can come in with a new and improved package. The next speaker, the last speaker before the coffee break, is Dr. Ashwani Kumar, and he was, until 2 weeks ago, the director of the Vector Control Research Center in India, and now has a post as a professor in a medical college in Chennai. Dr. Kumar.
Thank you, Professor Gary, Dr. Jonathan, Dr. Kathy, Dr. Tandon, and a whole lot of colleagues here in the room. India has the distinction of being the most populous country now in the world, surpassing China. And that's not a good news, though. The other very important thing about India is that it has 40% of the entire global burden of lymphatic filariasis in one country. We have 766 districts in the country, and we have 328 endemic districts in the country. Burden is that high. That's 42.8% of the entire country, roughly about 600 million people living under the risk of this particular disease. So I'm going to share with you our experiences, which are not as great as we have heard from our colleague from Kenya. But nevertheless, yesterday's observations that India should not be treated as a country but as a subcontinent, I echo the same. It's a very, very diverse country. In terms of populations, cultures, in terms of how health systems are in different states and how they are implemented, because health is a state subject in our country, and we have 27 states and some union territories. Implementing health guidelines of national program supposed to implement uniformly, but then the health system weaknesses and strengths make a big difference in our country. So our Ministry of Health endorsed this MDA strategy, IDA strategy, in way back in 2018 and 2008. Then we started working on M&E strategies as Indian Council of Medical Research in 2 districts of the country. And Professor Gary asked me to present only one district, that is for the sake of time. And, but that is quite revealing in itself. And the idea was to develop M&E strategy for this complex country. And that was to make a M&E strategy that would actually enable us to stop MDA and take a decision to stop MDA without resurgence. So here are those 2 states. One is on the eastern side, that is the state of Jharkhand, and this red is the district which is Simdega, the result of which I'm going to present. And the second state is down south, which is Karnataka, where we implemented this M&E strategy protocol in a district called Yadgir, but I'm going to restrict my presentation to this district. This was incidentally an MDA naive district, but it was discovered that this was endemic for LF, so this was an opportunity to introduce in this district straightway IDA. And we involved 7 CHCs, 18 wards, 519 villages, and 0.66 million population. And here is the methodology. The design was that we would be actually carrying out baseline assessment and then a follow-up assessment after first MDA and then the second MDA. And this was started in 2019, just before the pandemic started. And the program was to be implemented selecting 30 clusters using PPES sampling plan in all these assessment rounds. And while this assessment was done, if any of these random sites would have very high incidence, 5 of these clusters would be added to the sentinel sites that were selected. So we had progressively 5, 10, and 15 clusters where this was followed. And this is how the distribution of these sample sizes were. We selected age classes 5 to 9 and more than 10. And these were the number of people followed. Consistent as far as this is concerned, while the numbers kept on increasing when we added more sites to these. And we had followed up in sentinel sites, 9,000 in the second round. It so happened that due to pandemic, we could not follow the second round, and therefore we were forced to follow up after third round of MDA in this district. And we also did xenomonitoring in these sites, the random sites as well as the sentinel sites. Here, we collected 7,500 mosquitoes in these 30 clusters, 30 sites. And 5 households were selected in each of these clusters. And we deployed 2 gravid traps. And each one of that was supposed to collect at least 25 mosquitoes, so that we had 50 mosquitoes from these in these 2 pools, and in 5 each in 5 households in 30 clusters, totaling to about 7,500, which were assayed for L3 larvae. And similarly, similar plan was executed for the sentinel sites. And as far as the coverage evaluation surveys were concerned, interestingly, the coverage here was much higher than the 65% threshold level. And some of the experts feel that IDA coverage should be more than 80%. At least 80% should be the threshold, rather than 65%, which was actually the threshold for the DA. And these are the results of the circulating filarial antigen with FTS. The blue bars is the baseline, the orange bars post-MDA1 and post-MDA3. Not a great news, actually. Not a great sight to see when you consider that many of these sites actually had not significant reduction when you see the 95% confidence intervals overlapping with the post-MDA1 and the baseline in different clusters. And MF prevalence, the story is the same. These are different sites that could be covered in the baseline, and one of them could not be taken up. And so the story is that most of them, even post-MDA level 3, much higher than the threshold level of 1%. And as far as the community surveys were concerned, here is the result. As far as the MF prevalence is concerned, and this indicates that the impact was suboptimal, much less than expected. And these are the results of the molecular xenomonitoring, which is supposed to be 0.25 as cutoff, which is an arbitrary cutoff. In all the places where this was done, it's far higher, showing that the impact was much less than expected. However, if you compare overall, when you club these all sites together, you see that there is a decline as far as the CFA is concerned, progressively over the 10 years of age, but still much higher than the threshold level of 2% in case of adults as well as children. As far as MF prevalence is concerned, again, there is decline, but there is unfortunately, 95% confidence interval is overlapping. As far as xenomonitoring is concerned, is a very bad news. It's just remained the same. So in summary, of course, the effective coverage was achieved, more or less. The impact of IDA rounds was actually not so promising, and no significant reduction in MF prevalence was seen in this district. And the MF prevalence of more than 1%, CFA prevalence of 2%, and vector infection shows that there was an ongoing transmission in spite of this IDA introduction in this district. And vector infection and the human infections actually were, we can say that they indicate the similar trends story. So in conclusion, 2 to 3 rounds of MDA perhaps are not sufficient to reach LF elimination threshold. Community-specific target strategies may be essential to improve the coverage to achieve the desired impact. And the suboptimal impact in spite of effective coverage in SIMDEGA could be, when we did the follow-up surveys, could be due to partial consumption, due to recall bias or the response bias. And molecular xenomonitoring could be an alternative tool to actually correlate with human infection or measure human infection. Purposive sampled sites with high risk could be appropriate to monitor the impact of IDA MDA program to identify the hotspots. So I must thank COR-NTD, the World Health Organization. We are their collaborating center, ICMR, and moreover, the National Program of India. Thank you very much for the discussion.
Thank you, Dr. Kumar. You know, we have a couple of minutes before the coffee break, so I think it would be great to take questions for Dr. Kumar's presentation while the thoughts are fresh in your mind. Results were not as good as anticipated or what we had hoped. And one question I have, I'll start it. Among those people who were MF positive after let's say after the third round, was there any investigation to see did they claim they had taken the medicine, or maybe they had been missed somehow? You know.
We need to look at the data. I have no ready answer whether we did ask pointed question that way, that whether they had consumed or not. Essentially, these were the same places where, which we followed up as far as. So we believe that if the numbers are to be believed, then the sample should tell us the story, what happened in the universe, what was happening.
Yes.
Thank you very much for your presentation. So I think you get a great data. And my question is about you said you did a coverage evaluation survey, but you didn't talk about the result. How was the result of those coverage evaluation survey? And the second thing is about the sub-district data analysis. Did you do that to see the cluster where you get a lot of positive cases? If there is a kind of correlation with MDA coverage rate? Thank you very much. Did you get my question?
Not very clear, perhaps.
He asked whether you did coverage evaluation survey. I think he did that, but he presented that. They did a coverage evaluation survey. He asked about geographic within the district, where there are some areas that were much higher than the others, if you looked at the geography of where the positives were.
Oh, well, if you see the baseline and the areas where we introduced IDA, there's a high variability in terms of CFA and the infection. So obviously it's an heterogeneous disease anywhere, wherever it is found. So there are hotspots, there are hyper-endemic areas, there are low-endemic areas. There is a village-to-village variation. So all were taken care of when the sample was built.
If you looked at the map, was there one part of the district that was much higher? Would you be able to say, oh, this part of the district did fine, and this part needs more focus, and you can focus further effort?
So that analysis could be done. Yeah, analysis. Yes, yes, please.
Thank you very much for the presentation, and my comment is for both countries, India and Kenya. I think regardless the regimen we are using, coverage remains something critical. And when I saw the outcome of the IDA in Kenya, maybe I didn't get what he called target population. But if target population is the eligible population, I'm not sure that the coverage is very high or enough high in 2 of the districts. And I also saw coverage like 111% in a district. It's, well, you know, garbage in, garbage out. We need to be sure that we are assessing something that really happened. Otherwise, we will be building on a castle on a sand. So over to you, and coverage is critical. I don't know how we should do to make sure that we are making it right.
Yeah. So as far as India is concerned, the claim of the national program, I mean, we did not achieve 111, so I can't answer that. I wish we could achieve that. Impact would have been perhaps better. So, but as far as India is concerned, the claim of the program was 85% and we got 83%, so they're quite similar. However, the follow-up of the CES, the coverage evaluation surveys, is actually about few months after the MDA has taken place. So there can be an element of recall bias. And as I mentioned yesterday, these are very poor communities, and they get governmental benefits of the governmental programs. And maybe there is an element, this is a speculation and need to be tested, checked, whether they tend to say yes if they have to actually say no. So they get recorded in yes, that they have consumed the drug. It's not about receiving the drugs. Actually, we are talking about the actual consumption of the drug. And that would in turn will make impact. So therefore, this kind of study is very, very critical as to the distributed drug is actually consumed. So that's why the intention is to give in the form of DARTs, and DARTs perhaps with this kind of population and only one day allotted and some mop-up of rounds that are taken up later, using the local worker who is the village worker perhaps could be one of the strategies. And before I forget this, and I give chance to my colleague to respond, we will be talking about additional tools, and I think that the vector control is actually missing. We are not talking about vector control at all. And I strongly believe that vector control can be very critical in making a difference, and perhaps LLINs, which is a $4 intervention, self-drawn, and has made so much impact on malaria scenario all over the world, including India, perhaps could also be used as a strategy which can last for 3 years, self-used, because people will not be bitten and they will have sound sleep, and that will take care of the Culex incufficiatus nuisance as well, and would cut off the transmission. So I will very strongly advocate introduction of LLANs to the policymakers and the decision makers.
Thank you very much, Yao, for that exciting comment. But I'm lucky today that I'm not defending the program without the program manager. He is in the room. So he needs to explain to us how the program came up with the more than 100% coverage. Wycliffe.
Thank you so much, Professor Njenga. I think one of the questions my Indian colleague did not answer was whether they had the results for the coverage evaluation survey. So in our context, what Professor Njenga presented is the reported coverage from the country, which is a product of what WHO provides, the number of people who have ingested medicines over the total population, projected population of that particular IU. It gives you the coverage that Professor Njenga presented. Then we follow that with coverage evaluation, and in our context, the coverage evaluation was in sync with what was reported. That is the first thing I wanted to provide. Number two, you look at the 3 IUs we implemented. The Lamu is to the extreme end, while Jomvu, where we had 111%, is a sub-county sandwiched within other 5 sub-counties in urban setup. Now, due to the enhanced advocacy, the other people came from the other nearby sub-counties to take the IDA. So you cannot refuse to give them this medication. So we report what was ingested. So it's not garbage in as it is being portrayed. Thank you.
Thank you. Well, that's a good explanation. I think now we'll take our break. Please be back in 15 minutes. So we kept to time pretty well at the beginning. It was hard to get people back from coffee, which is understandable. The next speaker We have two more talks, and there's a question period. We've already taken care of the questions for a couple of the presentations, so maybe we'll gain some time back there. And then we have, I think it's the kind of juicy part of the session, will be breaking up into small breakout groups to discuss the reassigned topics. The next speaker then is Chris King. He's a professor of medicine and pathology and probably other departments at Case Western University, who was very important in the clinical trials for IDA, and now he'll present on the IDA rollout study that was done in Papua New Guinea.
Thank you very much, Gary. I think the other speakers have actually given some of the background that may be valuable on this. So, right. There you go. Okay, lymphatic filariasis in Papua New Guinea. I guess Alison Krental mentioned a little bit of this, and as well as Jonathan King. But anyway, population is about 10 million people. There's probably a good 2/3 of the people that's still at risk of LF. There's 15 of 22 provinces, and the province is the evaluation unit in Papua New Guinea. And there's only 2 provinces that have received MDA for LF. Jonathan mentioned that New Ireland province, which is up over here, an island province, had received the 2-drug regimen for 3 years, interrupted by a couple of years, and then did one time of the triple drug and passed TAS in 2019 using the standard DAS protocol. Eastern Britain is the first province to use triple drug. And as you can see, and I'll be talking about that, the monitoring evaluation and the MD program over the next few slides. As was discussed by other people, we have basically the objectives here, and bold, is demonstrate the impact of 1 and 2 rounds of IDI and LF infection in humans. I'm not going to present the work on mosquitoes, that's still ongoing, justifying a new elimination criteria for endpoints, and optimizing the sample strategy to demonstrate elimination of LF. So we approach it 2 different kinds of survey methods we've done. We've done 3 surveys already in Eastern Britain province, and we're undergoing the last survey. And like what we've done both in Kenya and in India, we used this kind of strategy that was probably developed by the COR-NTD in 2018, and using a population proportional sampling, as we've discussed in the previous studies, about 100 per cluster split between children and older children and adults. If you knew that there was 5 purposeful communities, that we knew that there was a high LF prevalence from previous studies, we included those, and we did FTS positive and did the MF night blood. And I'll talk about that. So we've changed over, so over this next 3 years, there are a lot of new ideas coming up in sampling strategies. And we started to incorporate this IDA impact survey that Jonathan King was talking about that we're ongoing now after the second round of MDA. And we talked about the transmission thresholds. You're all well aware of this. For the TAS, less than 2% for CFA, less than 1% seats in cluster-based surveys in children. IDA impact really focusing on the MF positivity, because CFA does not decline rapidly because IDA does not kill all the adults but sterilizes them. So this is Eastern Britain province, to give you perspective. It's a very challenging place. It's got about 376,000 divided into 4 districts. It's very rugged area here. This northeastern part of the province or peninsula here, or island, is where it's not as mountainous and where the bulk of the population lives. Up here, these are more sparsely populated. As you can see, it's very rugged territory. So this is the overall timeline and approach. As you can see on the left-hand side, we did the baseline surveys in 2019 as they were done on the other studies. The first round of MDA occurred at the end of 2019, and they had 82 reported % coverage, and that was confirmed by coverage surveys that were well done. And even in young adult men, they had over 80% coverage. And as you could see, we did another xenomonitoring acceptability surveys, and Allison reported on that. So then we did the second round of monitoring and evaluation in in 2000, 2020. This is obviously delayed. Then the second round of coverage, MDA, was done in 2022, 68% coverage. Unfortunately, the coverage survey was not done properly, so I'm not sure we can rely on that. But if the first one was done, it's pretty good. And then we're doing the third M&E that's ongoing now, and I'm going to mention that at the end. So this is overall, just to give you a perspective of what the going on. We oversampled. We did 49 different clusters, about over 100 in each cluster. And you can see the prevalence here. Black is in circulating filarial antigen. Red is in microfilariemia rates. There's a lot of high confidence intervals. But what you can see here is a very heterogeneous distribution of infections. Some individuals that have really quite high in a couple villages, there is over 40%, even 20% MF rates, and other areas that have MF rates that, again, over the thresholds here, and other areas that showed almost no LF. And overall, we saw out of this is just a 5% CF rate and 1%. So now we sort of broke this, and then this is the distribution. You can see that on the left-hand side is circulating filarial antigen, and this should be CFA and MF, and this is on the right-hand side. But these large circles represent MF rates that are over the thresholds. In the Duke of York Islands, we'll get back, there are several villages that had very high infections that I showed before. But you can see the heterogeneous population, and certainly the undersampling in areas in Pomio. So what I wanted to do is what we wanted to do is separate how we did these kind of sampling regimes. So if we did population proportional sampling, which is recommended in the new IDA impact survey and also before, you can see that out of these 30 villages, and each one represents the prevalence rate in a community, a cluster, and there are only 9 of the 30 clusters had over the threshold of 2%, and 8 were over the threshold of microfilariemia. So if you would take the overall prevalence rates using this population proportional sampling, you barely achieve the cutoff of something that has endemic for lymphatic filariasis. So really misses the high heterogeneity. So we're fortunate in Eastern Britain province that we had some good preliminary data of LF in those Duke of York Islands, and you can see there are much higher infection rates, both by circulating antigen and microfilariemia. Because when we went along and sampled, we found that we really undersampled the rural areas, we went ahead and started doing more samples, purposeful samplings in rural areas, and again, picking up more infection rates there. So again, what was the impact of sampling children versus adults? Again, we can see the children less than 10, this is about almost half the population initially, very low prevalence rates in children, and obviously higher in adults, and the young men are the ones that had the highest infection rates. So what we changed is that population proportional sampling, we determined, really failed to captured clustered primarily in the urban areas and less LF in the rural areas. And we didn't get as much information looking at these children for these surveys, and more adults were more sensitive. And I think these ideas have been, again, incorporated into some of the new IDA impact surveys. So in order to try to do this better and try to get a better collection of it, we were impressed by the work that the geostatistical modeling has been done for LF and certainly other diseases. So we worked with Emanuele Giorgi to develop a geostatistical model, which he had done already for LF, but we added some additions to it. We went ahead and added the facts that of socioeconomic status, which we looked at. We also added some information about malaria, because malaria shares the same vector in Papua New Guinea, and we have very good malaria data that's reported with a RAM every 3 years. So we put that into the model, and using that, we were able to develop a probability distribution of where LF is. And so, and a lot of you are familiar with this geostatistical modeling, but you can see areas that are dark red are probability that they're unlikely to be, or have high probability that they're not less than 2% or have high probability of LF. And this is based on those multiple parameters, covariates, as well as pretty good sampling data for LF that was already done. So based upon that, we went ahead and selected another set of villages. We aimed to get 50 villages selecting on that. We wanted to oversample. And then by doing that, we ended up selecting, of course, the hot spots. We identified 24 hot spots in the initial survey, which means greater than 2% circulating filarial antigens. But we also identified a lot of other communities that were and had LF outside of the ones that we've been previously surveyed. And those are overall, based on less than 50%, were picked up with having LF in our initial population proportional sampling. We picked up over 80% of villages. And again, don't want to go into this too much, but as we did the second time around sampling after the first round of MDA, we focused more on older children and adults. So here's the data in the same set, a lot of the same villages. The black ones, the ones were highlighted, the ones that we had done before, and the lightning ones are the new villages selected, but you can see compared to the previous one, most of the villages you see are actually above the threshold for presence of LF at the margin of 2%. So obviously, a much more efficient way of capturing LF-infected villages. But notable is the striking levels of MF. And so you can see there's only these few villages in the Duke of York Island that remain above the threshold. Most are at the threshold or slightly below. And this is particularly notable in the Gazelle province, which is by far the most populous province and one of the rural provinces, so highly successful in getting there, and then Rabaul also. And this is represented by the same distribution here. You can still see in the Duke of York Island there's MF positives, and then a few villages here that have about 1% or just below the threshold, because they were sampling about 100 individuals, and they just had one MF positive individual. So again, what happens when you look at the clusters that we look both pre and post infections, and we had 23 villages that we looked at. We looked at individual 18 and older, so we compared apples to apples, and we wanted to look at the rates of CFA at baseline in 12 months, and you can see, not surprisingly, the circulating filarial antigen didn't decrease very much, a little bit, variably, because triple drug does not kill all the adult worms, but very good at killing the microfilariae and sustaining it, and we could see many villages became amicrofilariamic, but still, those that still had the high prevalence still had individuals who remained microfilariamic. So we wanted to ask why. What's the other questions? So we went back and identified all the MF positive individuals after that, and we went back and asked them, did you take treatment? And initially they said they did, and then we went back again and we did this, collected the blood samples, and a lot of people admitted they didn't, and they were positive, and when we treated them, I won't go into this, and followed them up at 14 years later, almost all of them became amicrofilarial and stayed that way, except for one person that had 2 microfilariae, and that may have even got reinfections. So in conclusion, the data support monitoring MF in adults as an endpoint. Geostatistical mapping may be better than capturing the heterogeneity, particularly if we go into the other areas. And EU with initial prevalence with high MDA coverage may require only 1 round of MDA. So I quickly want to go in and what we're doing now, and this is ongoing. So we're doing this step here. First step is we want to do is we went this sort of like pre-task, or what Jonathan commented is go to those villages with high known prevalence. So we took 7 villages that had MF after the first round of MDA, and we went back and again surveyed those and randomly selected the individuals from those communities and sampled 110 adults in each one, and that's over 700, and I'll show you data there. The next step was something that's a little different. We went back to Emanuele and said, can we calculate the probability of either having high or low possibility of LF based on the geostatistical model? And so what we did is we focused on village that we had most unknown. So an exceedance probability that we don't know what the coverage is, one that has exceedance probability of 1, very likely to have LF based upon previous in those models. The probability of 0 or 0.1 or 0.2 would be low. So he generated a list of all the communities within the East New Britain province. And we started with the first 150, so you can see here's the exceedance probability, and you can see some are all sitting around 0.5, a little higher and lower. And those were the villages we went down and sampled. and this is the initial results. And the problem is that the thing is that we end up sampling heavily in Gazelle province, and just like we have the first round of MD, all are MF negative, so we're successful there. This is the heavy bold one, was what we like pre-task or that initial doing. sampling in these kind of areas, and you take out of 700 people that we sampled, you see 5 people are MF positive, so that would be below the 1% cutoff, but there is this one village that's very high that still has elevated MF. Where also problem is that the surveilling those areas that have 0.5 exceeding probability are those most remote villages and very difficult to get into. So that's what we're doing right now. We sent teams down there, they boot us back, so we're aiming to sample another probably 20 more villages in the Pomio districts in the most remote areas, so that's ongoing. So basically, this idea of surveillance of clusters with 0.5 or what we have high levels of unknowns, often in areas that are very remote and challenging in cost of sampling. So we're working about trying to develop a model to sample between unknown and the cost. How to use modeling compared to WHO population proportional sampling for ID impact surveys, so we're exploring that. And what is the approach for repeating if only one cluster exceeds this threshold of 1% that we currently doing? Do we go back and treat the whole area, or do we go back and treat that one village? And so I want to get some of the impact on that. So anyway, so this is acknowledgments for very, like all the other places, is many, many people contributed to this, a lot of work. So thank you very much.
So these are very exciting results. Here in New Guinea, this did work like a magic eraser and essentially erased filariasis the way we hoped it would work everywhere. Lost in his presentation, but important, if they had done a task survey of children at baseline, this area would have passed, and it had significant LF. So it kind of shows in some areas that children are not the appropriate sentinel population for assessing whether LF is present. The second point is that the geostatistical modeling of the areas that they predicted might be at high risk, a high percentage of them were positive when they resurveyed, so it was very valuable there. Question is how widely or how generalizable can that be applied in other areas, but it worked really well in this area. So what I'd like to do is move to the next presentation, and then we'll take questions for those, for focusing on those 2 presentations, but also have all the presenters come up to take questions after that. So the next presentation is by Professor Tanya Wati Supali from the University of Indonesia, who is a professor, and she comes from the long line of, she was trained by Felix Partono, and she knows as much about filariasis in Indonesia as anyone.
Thank you, Gary. So good morning, everyone. Where is okay. So I'm going to share our work in the zoophilic Brugia malayi, the result of the first IDA impact survey, and the study area is in Belitung district in Indonesia. Thank you. So lymphatic filariasis is endemic in Indonesia, and Indonesia is the only country in the world with 3 filarial parasites, WB, Brugia malayi, and Brugia timori. And 236 districts in Indonesia are endemic for LF, and almost 80% of the endemic district known as endemics for Brugia species. And for Brugia, we have 2 types of Brugia malayi, zoonotic and anthropophilic. And we also have the Brugia timori. That's the only species of filarial parasite in Indonesia and Timor-Leste. And FDA with DEC plus albendazole was started in 2002 with full geographic coverage achieved in 2017. And in 2020, it was reported that 20 million people required MDA. And actually, IDA, triple drug treatment, was tested in the Brugia timori endemics area with the efficacy was 96%. So this slide shows the location of the Belitung Island, the Belitung Island is a small island close to Sumatra Island, and the island divided into two districts, Belitung and Belitung Timur. So the population there works in the agricultural and mining. And because of our government has a new regulation forbids the private mining, so open mining pits become a potential breeding site for mosquito. And both districts are endemic for Zoophilus brugia malayi. We did the survey, the first night blood survey done in 2021 during the Delta COVID-19. We was able to collect 1,911 patients, and we found 40 patients are MF positive. So 5 out of the 7 villages were endemic area for LF, with the MF ranging from 1.5 to 5.9%. And the highest MF rate was in the age group above 50 years old, and the MF rate was higher in men than in women. And all positive MF were treated with IDA by the Ministry of Health of Indonesia. So this slide shows the prevalence of the MF before and 1 year post IDA MDA. So the baseline, we collect again the sample in 2022. We collected about 6,253 patients, and again we found a new MF positive patient. We found 87. So this is 1.4%. And in 2023, we did a survey for 1 year post MDA. So we collected the sample from 4,173 patients, and we found 35 are still positive. So the MF rate is 0.8%. And most of the positive MF was in men, and men above 50 years old. So the problems and consideration to reinitiate LF intervention in the Belitung district, there was no budget actually for the post-task 3 surveillance, because this district actually received the, the certificate from our government as a reward because this district passed the task 3, and also the district doesn't prepare the budget to reinitiate the new MDA. And the last MDA was performed in 2010, and little expert left to plan the new IDA MDA, and acceptability to new MDA after failed efforts was unclear. Several independent post-task 3 survey actually indicate presence of MF cases in adults. The reason why Belitung was prematurely considered to be free of LF could be the task strategy using the antibody detection in children was insensitive for the Brugia filariasis. And the Brugia rapid test actually is a problem. The test is unreliable, and compliance to the MDA was lower than assumed. And also the reintroduction of the Brugia malayi for the potential animal reservoir, because now we know that this area is a Zoophilus brugia malayi endemic area. So improved MDA campaigns using the IDA was needed. And the new research project in collaboration between Universitas Indonesia and Washington University through the DOF project funded by Bill Melinda Gates Foundation created a momentum for the new effort to eliminate LF in the zoophilic Brugia malayi in Belitung by district, province, and federal officials. So there are several objectives to initiate IDA monitoring and evaluation project for the elimination of the Brugian filariasis. So the first objective was the situation analysis about the compliance to MDA. This is done by Alison and her team, and then reintroduction of MDA with an improved campaign using IDA. This is also done by Alison and her team. And the next objective, evaluation of the 2 rounds of IDA MDA provided by Ministry of Health using the IDA impact survey design, baseline, and 2 follow-up surveys. Here we present the result of the baseline survey and also the first year of follow-up. And then the feasibility of the genome monitoring for Brugia area, this is still ongoing now. And then evaluation to rule of the animal as a reservoir for Brugia malayi, detection of MF in cat, dog, monkeys, and also to assess the parasite density in animals, and also to characterize the strain of the Brugia malayi. This objective will be present in the ASTMH talk. And then population genomic, the whole genomic sequencing of the MF to identify the potential gene flow between Brugia malayi in animal and human. This topic also will be presented in the ASTMH by poster. And then the aim of this study actually is to make a recommendation towards most efficient monitoring and evaluation, and also surveillance to eliminate LF caused by Brugia malayi in Indonesia. So the coverage of the IDA MDA, it was reported that the average of the coverage was 91.72, but 42, actually 91.42, but there is one primary health center, number 4, reported that the treatment coverage is above 100%. And when we asked to the primary health center, they said that the primary health center treated the student from the other district, the Belitung Timur district, who are going to the school in the Belitung district. So that's the reason why the coverage is high. And then this slide shows the number of the adverse events reported by the primary health center. Only 6 primary health centers out of 9 reported the side effect. And the side effect, actually only mild adverse events were reported. And 3 primary health centers reported no adverse events. And this map shows the distribution of the endemic villages. For the baseline, we did a night blood survey in 26 villages. And we found that 16 villages are endemic for LF, with the MF rate above 1%. We found in 11 villages, and MF rate below 1% found in the 5 villages. And in 2023, we did the survey again, night blood, in 12 villages. The selection of the villages done by Emmanuel Georgi using the spatial village randomization. And the results show that 9 out of the 12 villages and 1 of the 2 palm plantations were endemics. And the MF rate above 1% found in 5 villages, and MF rate below 1% we found in 4 villages. Where is it? So the IDA efficacy in the community 1 year post MDA, in the baseline we found 87 MF positive patient, but we can only follow up 77 MF positive patient, and 10 MF positive patient we cannot follow up with several reasons. And the microscopic examination show that 64 out of the 77 MF positive are MF negative. So only 83% are negative, and 13 patients are still positive. And we found 22 new MF positive in 2003. So the total now is becoming 35 MF positive. That's from 9 endemic villages. And we also collect the animal in this study area. Domestic and wild animals were examined for MF. The detail of the result will be presented in the STMH. We found that 1.4% of 291 cats were positive for Brugia malayi with a low MF density. And 7.3 of 41 dogs also positive with the Brugia malayi with the MF density also low. And surprisingly, the prevalence of the infected monkeys is a bit high, 13.5%. And with some of the monkey have a high MF density, more than 1,000 in the 60 microliter blood slide. So is it possible that an animal reservoir is responsible or has contributed to the persistent or re-emerging of the Brugia filariasis in the Belitung district? So the summary, despite a previous MDA and 3 PASTA survey, Belitung is still endemic for the Brugian filariasis. And the MF prevalence in the school children was very low, and adults appear to be the best sentinel population for monitoring and evaluation. And after a situation analysis and susceptibility testing, MDA with IDA was successfully implemented in the Belitung, and Alison and her team reported that the coverage of the treatment is above the 70%. I think about 74%. And no moderate or severe adverse events after the IDA was reported to the health care center. And the IDA efficacy in the community is 83%. And despite the focus on the high risk area, using the geospatial modeling during the follow-up, the overall MF rate in adult dropped for 1.4% to 0.8. This showed the 43% reduction after 1 round of IDA. So the IDA impact survey design with focus on adult and geospatial modeling for the site selection appears suitable in our study area. In this study, we also found the infected Brugia malayi in the animals, cat, dogs, and monkeys. So the discussion and the conclusion, so MDA in Belitung has to be coordinated with the MDA in the adjacent Belitung Timur district, because one island divided into 2 districts, right? So that should be together to do the MDA. And Belitung Timur this year implemented the IDA MDA. So night blood collection in adult for MF detection is feasible in the research project. But for the program, a day blood screening for antibody combined with night blood follow-up in the small number of subjects is needed. So while animals cannot be treated with the microviral residual drug, hence the elimination of the animal reservoir for Brugia malayi in this study area, because the monkeys is the dominant infected with the Brugia is unlikely, and areas with zoophilic Brugia malayi should be declared as a special intervention zone and should receive intensively surveillance after task 3 or IDA impact survey have been passed. So other challenges for LF elimination, such as non-compliance with MDA, introduce of infection from other endemic area, or low sensitivity of task may apply also to the Brugia area. So elimination as a public health problem of LF caused by Brugia malayi is possible, but may require certain areas more attention. So the recommendation for LF area with the zoophilic Brugia and filariasis, actually we can follow the non-Brugia specific advice, such as to assess the compliance of MDA, to optimize the MDA program, or also to use the observation treatment. But there is also a specific recommendation in the Brugia malayi endemic area, especially in Indonesia. We have to identify the type of the Brugia malayi, whether zoophilic or anthropophilic or Brugia timori. And this is additional, we can also test the local periodicity in order to optimize the MF detection. The periodicity is also important to know when we should collect the blood in the animals. So monitoring and evaluation should focus on the high-risk population, adult, and surveillance may need a special survey targeting the highest risk population, and then conduct the night blood for MF detection, or combine the day and night blood survey. And in areas with the zoophilic Brugia malayi should be declared as a special intervention area. For zoophilic Brugia malayi, collect information about the potential animal reservoir is really important. So we should also consider one health intervention that may include intervention treatment, but this is only for the domestic animal, because if the infected animal is monkey, it's really difficult to treat. And then we also can consider other supportive measures, such as local vector control and also detailed mapping of the high transmission risk area. So thank you for your attention.
Thank you, Tanya. It's very interesting, quite different situation, special situation with the animal infection. This is an area that had passed task 3. Past task 3, 10 years later, some ad hoc surveillance identified infection in the area and then led to this study. So what we're going to do is we're running a little behind now. What I'd like is for Chris to come up and Tanya to take a few questions, and then we'll have Dr. Kumar and Dr. King, Jonathan King, come up and see and have final quick questions, and then we'll do our breakout. So are there any questions for Chris or Tanya? Yao, we asked last because he already asked the question. Yes.
Well, you will be happy that it's not a question, but a comment. When we started this program in 2000, there was a book, Program Manager's Manual, how to set up a program, LF program. And I think in the first 3 pages, it says, we will be learning by doing. And I have to say that you deliver the promise. The elders deliver the promise. We just saw that Jonathan presented the 3rd version of the M&E book. This cannot happen if you guys, you don't back up the program with research. LF program is not the most rich, but you did everything like it's a scientific program. You know, everything is done by evidence, and we're making progress by fact. So I'm so thrilled to be part of this program. And, you know, if you guys, you are not doing this, I think LF program cannot be where it is now. It's not easy for you. That's why I need to recognize it and congratulate you for the effort you have been doing so far. And also the founders, those who are putting dollars in these studies to guide the program to where we are now. So thank you so much for doing this. You happy? I'm not asking questions.
Thanks. Excellent presentations, just really rich data and lots of lessons to be learned. I think one lesson in particular is the comment about successfully passing task 3 and then essentially the disappearance of the program. That's a big lesson learned for many countries. My question, Dr. King, question to you specifically about, as I understood, the intentional selection of sites for pre-task being the worst performers. And I'm wondering if that doesn't unnecessarily prolong the program by requiring MDA in areas that may not necessarily need MDA. So you described very nice, robust geostatistical methodologies for determining assessment and risk levels. I'm wondering, has the program just considered a simple geographical programmatic assessment of areas that MDA may not be needed, because as I understood, some of these areas are incredibly remote, and those would most likely be the most costly and time-consuming to get to. So are there areas where the program could essentially contract and focus on? So just a methodological question about biasing towards the worst performers for pre-tests, if that indeed is the bar by which the overall area must jump in order to progress to tasks. Thanks.
Okay, well, thank you for the good question. You bring up a lot of important points that we're all trying to deal with. Certainly, as we see in LF, there's a tremendous heterogeneity of infections. And fortunately, in this province, they sort of knew the areas that were difficult in some ways. So we had this pre-selection. We're going into a second province where they had no information of where there's LF distribution. So I was trying to advocate, certainly, because after first round of MDA, some areas were clearly had high coverage, after one round had shown no markers of significant LF, that's the Gazelle province, and could argue that may not be necessary to repeat the second round of MDA. So we're thinking of that kind of thing. However, they wanted to do the second round because that's the WHO criteria, and there's a lot of other benefits for these drugs as well. So the other question is that can you identify those areas a priori which are problems, and how do you deal with that? And so that's exactly what we're trying to deal with in that Eastern Britain or the Kokopo, Duke of York Islands. What do? We've done 2 rounds. We still identify a few villages that are still above the high LF. So what do? Do we create a small, or will we just go in and just treat that village? I don't know. We're trying to think about it. Jonathan? He may have a good answer to that question.
it keys up a good point that I didn't include because of time in the new M&E, in the second edition of the new M&E guidance. We are recommending in areas that pass TAS or IIS, the IDA Impact Survey, overall, those clusters that have 2 or more positives, you would do targeted treatment in those clusters. And in task 3, if you have 2 or more clusters with 2 or more positives, then I'm sorry, but that EU fails. And so, yeah, so this will help, I think, in this situation, that we'll have a little bit more response on following up positives in areas that have passed. Yeah.
Any other questions for these folks? Yes, Paul.
Yeah, this question is for the Indonesia program. I'm curious as to what the plans are as far as interventions in the special intervention zone. I mean, we've got an area where you passed task 3, you came back years later, you found there's ongoing transmission, you found zoonotic transmission, you've once declared that you've interrupted, you met the guidelines and the program disappeared and all your funding disappeared. Is there already a plan for what to do if it sounds like you're planning on doing another impact assessment. It seems clear to me that you probably wouldn't want to stop the program. You probably would not want to even stop necessarily MDA at that point in time. You could say you met the WHO guideline, you met the WHO target, but you've still got the risk of zoonotic transmission, and we don't know the answer to that. So I just didn't know what the plan for continued treatment even after passing the task might look like, or if that's been developed yet.
I'm going to, as an executive, defer that question because that's one of the discussion questions. And I think I can tell you they don't have a plan right now, so we're going to make the plan. Any other questions? I think if there are a question for Dr. Kumar or Jenga, we could take that now too, but they already answered some questions. Otherwise, I don't see any hands. Any hands? I'd like to give Dr. Sodalan another chance. Another endorsement of funding and additional work, yes.
Thank you very much for all the presentations. My question is, Dr. Kumar, I think that from the presentation that he made, the results of the IDA is quite unlike what we have seen elsewhere. From his perspective, what does he think is going on? You probably may not have followed up positives to ask them the question, did they take the medicines like what was done in the other studies? But I think you have a larger population to really ask them this question. In your view, what do you think is going on? And that perhaps should influence what you want to do next. Thank you.
I can only guess that perhaps the drug is not being consumed as is being claimed. That is the best answer I have at this moment. I think this might require strategies, communications, sociological interventions, making sure that people understand the importance of intervention, particularly for the children who actually receive infectious bites and manifestation is later. Probably communication, strong communication to these communities to actually consume drugs. The coverage and compliance may be two different things. Coverage means dispensing of drug. Compliance, in my opinion, is actually consumption of drug. So there could be a lot of difference between the two. And so I suspect that could be the reason of poor impact, because xenomonitoring actually is showing no impact. So that means transmission is on. It's as bad as it was during the baseline. So that clearly shows there was no impact of these 3 rounds, the 2 rounds. Third round is actually after second round, which happened during The pandemic, there was a very small window when it was done, and we do not know the quality of that round, actually. The third round, therefore, we asked our funding agency, the LF Support Center, whether it makes sense. They said, yes, you could follow. And we also talked to program people. They said, yes, we can do that. And so maybe a limited impact of second round, but then third round claim was that the coverage was pretty high. And I would say that we have to either ensure that people consume drug through DOTS or give longer window of actually these rounds rather than a particular day, maybe a week's time, give opportunity to drug dispensers to actually ensure that people are taking drug in their presence. That perhaps would make a difference. Thank you.
Dr. Kumar, you're going to be first, and you can bring the notes if you like, but to summarize. Yeah. Don't. Or we do. Okay, good.
Dr. Philip will proxy on my behalf.
That's a delegation of assignments here. So the first question was, are new tools needed to help program managers, CDDs, and supervisors in areas that use IDA? And our discussion about new tools began with a discussion about political will, support, coordination, and coordination both with other NTD programs or other government programs, but also with other programs such as tools such as vector control. Essentially the idea was that if you're going to implement a new program, you have to have a coordinated response with political will and with engagement of multiple targets, multiple shareholders. Mentioned again was integration with other programs, observed treatment, enhanced and serious commitment to adverse event monitoring and pharmacovigilance, so that people feel reassured that should adverse events occur, that they will be taken care of. And increased community engagement. Increased community engagement came up in other questions as well. So the second topic was what tailored messaging is needed for targeted communities. One of the themes there was that we're not sure in each community what the tailored messaging is, and so we need to make a concerted effort to discover that. And one of the tools that we thought would be useful was a communication framework for extracting that information from the community, for going to the community and figuring out what their local concerns are. We need to focus on what the local concerns are that lead to non-participation. Consider multiple platforms for reaching populations, and by platforms we meant mechanisms of drug delivery, whether it's door-to-door or posts, or reaching out via social media, or reaching out via places of worship or places of work, that we should consider multiple platforms. Another suggestion was, is there a way to collate qualitative local experiences into a shareable database that would allow us as a community to better learn from each other in terms of local strategies? Recruitment of community champions, celebrities, sports figures, people that could lead the way in showing that adherence or participation is something that's important. And then one theme that bled over into the other topic was this idea that communities are more likely to participate if we share and make them more of a stakeholder. So sharing successes or data with the community about how we're doing with this, whether we're making progress, whether other places are making progress, would be a way to both encourage them but also to help them take some ownership of the problem. Did I miss anything? Okay, thank you. Yes. Yeah, so testable strategies to overcome MDA fatigue, because it was the third one, got a little bit short shrift, but this idea of community sharing of the data and of the progress of the program sort of bled over into that. But I think really, you know, we've talked about a lot of tools that could potentially be testable strategies.
Yeah, the testable strategies part is because they want to come up with new ideas for operational research. Here, Katie will present from her group.
Great. We had a lot of good ideas related to lessons learned from the monitoring and evaluation that we saw presented during this session. And I tried to distill them into 4 themes. The first is the importance of social science. And so really needing to focus on directly observed treatment, appreciating the local context and targeting the messages to help boost coverage, and recognizing the importance of adult males and figuring out how to increase treatment and the swallowing of the drugs among that population. The other big theme was data-driven programs. So focusing on smaller evaluation units to reduce the heterogeneity, analyzing your data at smaller scales. So just because it's collected at the evaluation unit doesn't mean you can only analyze it at the evaluation unit. Overlaying the different data sources, so looking at coverage data as well as prevalence data. Adapting your survey design, so using what you learned from a previous survey to inform where you look in future surveys. Yes, and using data to then prioritize your program actions during an MDA, where to focus more of your resources. The other theme was in quality. Quality of the mass drug administration itself, and also quality of the M&E, and not neglecting the training of the people who do your M&E to make sure that you don't have garbage data out. And then finally, PVS. Don't neglect PVS, because we don't want to close a program and then find out many, many years later that there's a signal, and the opportunity that molecular xenome monitoring may present during the post-validation surveillance period. Anything I missed, or anything people want to add? Yeah, so using tools like the supervisor's coverage tool to see who you're treating or who you're not treating during the MDA, so you can do mop-up while the groups are still mobilized to deliver the drugs.
Any questions for Katie?
Can we use AI tools to somehow integrate with GPS coordinate when the drug is being given? Because nowadays, smartphones are quite common.
Yeah. Did everyone hear your question? So the use of AI tools during MDA to see where. Yeah, I'll turn to the group. Has anybody used real-time GPS coverage data? I've heard of it like in malaria and other places, but what about in NTDs?
So yes, so that we can have better understanding of the coverage actually, and people moving from place to place. Maybe they can click once they have dispensed the drug and consumed the drug. Is that possible?
So, not the real-time geographical data, but the real-time reporting from every day from the field team is coming to the program manager, state program manager. So they can punch the data on every evening, so how many coverage is covered by each DA or each team. So that data is received by the program manager, and they can act on that. That is happening.
Right. I mean, it sounds like actually if you had 2 days and you can cover more, but then it costs more. So there's, Peter Fisher is all that is between us and lunch. So.
Yeah, so I need to go there just to have a. So the first thing was test strategies other than MDA of humans to eliminate LF in areas with zoonotic Brugian filariasis. And we discussed, of course, you can treat animals, but if you treat animals, you have to know exactly where is your reservoir. If you just randomly treat all cats and monkeys are infected or even rodents are infected, it won't help. So you need a lot of information if you want to do treatment of animals. The other thing we discussed was vector control. But also for vector control, unfortunately also for Brugian filariasis, we know the least about the natural vectors. And for these zoonotic areas, it is supposed to be Mansonia. We had in Bilitung difficulties collecting large numbers of Mansonia and collected huge numbers of Amigurus. So we are working on these mosquitoes. So in order to tailor some vector control, you also have to do some research on what are the vectors. You need to know exactly what the vectors are because there is a gap of knowledge. With regard to the best option for assessing the impact of IDA in areas with Brugian filariasis, we were all happy with the new guidelines that use a screening test, and we need to have a reliable antibody screening test, and then follow up at night. For microfilaria, we were happy with this. It is helpful if you know something about the periodicity of your local Brugia strain, because then you know if it is sufficient to do the night blood surveys at 6 or 7 p.m. or if you have to do the microfilaria assessment at midnight or so. That's something you, would be helpful to know. With regard to research priority, we talked about the vector, research on vector, then optimize really the treatment, and also as a research question, we also talked about certain population groups that are difficult to approach with MDA or with treatment, like adult males. So we had the same thing. And we also talked about, so far in areas with Brugian filariasis, it's not necessarily only a problem of the health, the district health authorities. You need to have somehow a One Health approach. You need to also work together with the veterinarians to really figure out what is a local reservoir, because not everywhere where there are, monkeys, for example, that there is also human filariasis. That's human Brugia. It's really certain areas where we have, the parasites in the animals and in the humans, but in others not. We don't know what are the factors for that. With regard as why IDA is not sometimes not working. In Bankofti areas, we talked about, like in Fiji, for example, we still don't know what is the reason for that. Is it really only compliance, or is there something else? We don't know. That's something what we need to study. And with regard to the adult males I just mentioned, that's all what we discussed.
Alternate end game strategy? No. Okay. All right. Well, this is not the last word on these topics, but I think this was a good session, probably the best session in COR-NTD. People have been saying it's the best session. And the best comment was Dr. Yao, who isn't here anymore. So anyway, thank you so much for participating. Thank you to each of the speakers for preparing their talks and for the delightful discussion. And we didn't have enough time really for the small group session, but at least it was somewhat useful to allow some people to get some input. So thank you very much, and we'll see you later in the week.